Hi, today's flashcard presentation will be on pneumothoraxes. A pneumothorax is air in the pleural cavity. There are two major types, primary or spontaneous pneumothorax, which occur in the absence of an underlying lung disease, and secondary pneumothorax, which occur as a complication of an underlying lung disease. The normal pleural pressure within the lungs is -2 to -40 centimeters of water. This negative intrapleural pressure holds the lungs against the chest walls, and when there is a disruption in the surface of the lung, such as a tear or erosion from a tumor, the air will flow from outside of the lung and into the pleural space, which prevents the lungs' ability to recoil and they substantially collapse. This change in pressure causes a decrease in the vital capacity of the lungs and also a decrease in partial pressure of arterial oxygen, which in most cases can be tolerated by healthy patients. Patients with underlying lung disease, however, will most likely not be able to tolerate the decrease in vital capacity and suffer from respiratory distress. So I'm just going to scroll down here so I can show you the image that I chose to represent the pneumothorax, because here you can see the pink tissue that is a normal healthy lung able to inflate and deflate to its maximum capacity, so the vital capacity of the lung allowing maximum fill here against the pleural space. And then an unhealthy lung, or the lung that's suffering from the pneumothorax, you see the damage in the lung tissue here, and the air is leaking from the lung into the pleural space, causing an increased amount of pressure in the pleural space and not pushing against the lung, which is preventing it from inflating to its maximum capacity. So tension pneumothoraxes are another type of pneumothorax, and these are considered the most serious type. They're always considered a life-threatening emergency. This abnormality can happen from either an opening in the chest wall and parietal pleura or from a tear in the lung tissue and visceral pleura. A one-way valve develops, opening on inspiration and closing on expiration, which allows air into the pleural cavity and increases the pleural pressure. If this continues over a period of time, the pressure is not released, the patient will suffer from a mediastinal shift. The pressure can push against the superior vena cava, which will affect the heart, and it will push up against the unaffected lung. These patients will present with severe hypoxia and respiratory distress, which develops quickly. The risk factors involved with spontaneous pneumothoraxes, they occur 3 to 6 times more often in men than women, and they're predominantly seen in tall, thin men between the ages of 10 and 30 years old. There is a genetic predisposition that's associated with spontaneous pneumothorax, and smoking also increases the risk. For a secondary pneumothorax, like I had mentioned, these patients will have an underlying lung disease. So the patients who are at higher risk are older patients that are over the age of 55, as well as those suffering from COPD, cystic fibrosis, lung malignancies, HIV, and necrotizing lung infections. Patients will present with signs and symptoms that include acute and sudden onset of dyspnea and pleuritic chest pain. When auscultating lung sounds, you'll notice a decreased amount of air movement in the affected side, and the patients will have labored breathing, usually using accessory muscles to help their dyspnea. Diagnostic testing, the provider may choose to obtain an arterial blood gas, but if the patient has no underlying lung disease or lung problems, then that may remain normal. If the patient's experiencing large amounts of pain, anxiety, or hypoxemia, the patient's hyperventilation will lower the CO2 levels, creating respiratory alkalosis that can be noted on blood gas. To get a definitive diagnosis of a pneumothorax, a chest x-ray should be obtained. And then to treat a pneumothorax, a thoracostomy tube will be placed. The tube is placed via an incision between the 4th and 5th intercostal space in the anterior axillary or mid-axillary line, and the tube, the tube will be connected to the chest tube will be connected to low wall suction, which will pull the air out of the pleural space, allowing the lung to re-expand and reach its maximum vital capacity or reach its full potential of inflating to its full capacity. And that's my presentation on pneumothorax. I hope you learned something new, and thank you very much.